On behalf of the American Academy of Neurology and in collaboration with Neurology Today, it gives me great pleasure to introduce two of my colleagues, Dr. Bruce Cohen, Professor of Pediatrics at Northeast Ohio Medical University and Director of Neurodevelopmental Science Center at Akron Children's Hospital. Through the American Academy of Neurology, he serves several roles. First, as the CPT advisor for the AAN. He's also a member of the Health Policy Subcommittee and the Copay Subcommittee. And then I'd also like to introduce Hollie Hristov. Hollie Hristov is a nurse practitioner at Weill Cornell Medicine and the Alzheimer's Prevention Clinic. She also directs clinical operations for our Women's Brain Initiative at Weill Cornell and New York Presbyterian. And today I'm really excited to talk about coding. This is the first time I've ever used the term excited and coding in the same sentence because I guess I've always just had a tough time with coding. What coding to use, what the billing means. So I've kind of tried to shy away from this stuff, but in the era of telemedicine with COVID-19, I've had to really learn. And Bruce, you know, I've listened to recently the Neurobite that you did on the topic. And for those watching that don't know what Neurobites is, it's a short 3-minute video. It's released on the AAN YouTube channel. It's also on the AAN website. That gives basically everything you need to know about coding in 3 minutes. And then I also watched a great billing and coding webinar actually through the AAN, also on YouTube. It was an hour. Your colleague Neil Busis actually did a really nice job starting at around minute 30 of the 60-minute webinar. One of the few webinars I've watched lately that like literally I've watched from minute 1 to minute 60. So I've learned a lot. And Hollie, you know, you've really been on the front lines applying these codes. Bruce, can you give us a little bit of an overview about since all this stuff happened with telemedicine, what tips and tricks do you have for a neurologist who's, you know, kind of changed their practice and having to learn the ins and outs of coding in the age of COVID and telemedicine?
Well, I want to acknowledge the fact that some people have gotten a renewed interest or a new interest in coding. There's a lot going on in the year 2000. We started this year on January 1st, terms like COVID-19, SARS-CoV-2, mitigate, surge, Zoom, social distancing, N95. None of us knew what that meant or what it was going to mean, and here we are just a few months later, and we're up to our eyeballs in these terms. Our lives have changed. So really what we're here to talk about today are 4 new buckets of codes. These are, what they have in common is that they're evaluation and management codes, which are it's another term for cognitive care, and that they're all non-face-to-face services. And so these 4 buckets include telephone services, online, digital, E&M coding, synchronous visits with audio and video links, and interprofessional consults, which we may get to if we have time at the end.
That's great. Well, you know, in the Neurobite that I loved, it really kind of separated out similar to that. They talked about the telephone codes. They talked about asynchronous, which to me, I guess means when a patient sends you something, an image or a video, and you can watch that and then you interact together, and then it has to be greater than 5 minutes. And then the synchronous video visits are kind of the thing that I guess have adopted most of my practice. I guess in the grand scheme of things, how do you recommend neurologists in practice learn about this stuff in a rigorous way so that they can get it right?
So I think there's 4 important parameters that we need to think about that will help us distinguish the differences about each of these codes and then help us try to figure out which one to use or how we want to run our practice. The first is whether it's synchronous or asynchronous. Again, synchronous are things like telephone calls and audio-video visits. And asynchronous are things like patients sending you a question and you responding at some defined later point, generally within a day. So that's the first parameter, synchronous or asynchronous. The second is video or no video. The third is what specific technology you're using. Is it a telephone? Is it email? Is it a secure portal? And the fourth is whether it's one session or multiple sessions. And if you take a look at these 4 parameters, each code that we have uses different sets of each of these 4. So, and then a lot of it has to do with how you want to set up your practice. We would just need to go through each of these different buckets one by one to figure out which one to use and under what circumstances.
Great. So Hollie, so you've really kind of taken the lead with our program in this area. Thanks for doing that, because I have, I don't know, coding anxiety and not COVID anxiety. I think I have that too, but coding anxiety for sure. What's it like been trying to adopt these codes? What's gone well? What's been difficult? And then in terms of, the billing aspect, different codes have different reimbursements. Has it been challenging to try to wrap your head around that? Or what's it been like when you've been seeing patients and trying to learn?
Yeah, I mean, initially it was pretty tough. So when we, the first few weeks of doing video visits were interesting. Lots of hurdles, lots of changes. Every day it seemed like there was a new change, getting an email, new update. But now, a few weeks into it, I guess over a month into it, it's definitely gotten a bit easier. I'm mostly doing, just like you, the video visits, the synchronous, I guess, visits. We have had a few which, are billed, from my understanding, just like you would if you were face-to-face with the patient. So that has been fairly easy, just as long as you're using that time to bill. In terms of the telephone visits, that's been a little bit more complicated because the reimbursement's not great. The charting is a bit different. But other than that, it's going fairly well. Yeah.
Okay. So Bruce, something that Hollie mentioned about documentation. And also specifically whether it's E&M billing versus time coding. We in our practice have actually, I know the reimbursements may not be as good, but we do a lot of counseling. So greater than 50% of our visits are counseling for sure. We review the history, we review the meds, review the usual stuff, but the assessment plan, answering questions, easily 60 to 70% of our visits. Could you talk to us a little bit about how we need to document the time? Initially when I was, thinking about using video visits through the electronic medical record, I guess in my head I said, oh, it's already electronic, so I bet it's tracked automatically. But then if we use the EMR, but the video fails, then you have to switch to Zoom or something else. And so we're not expecting the technology to track it for us. We're basically coding not when we started and when we ended, but just the total amount of time. Do you have any pearls about time coding and the differences and strengths and weaknesses or pros and cons about E&M versus other ways to bill?
So I've been giving E&M talks since 1997. And really for the last 10 years, my focus has been to neurologists, has been consider using time as a source of why you're submitting a particular claim, because our patients really, for the most part, don't pay us to, do another physical examination. Nothing's more important to the neurologist than an examination, but in the reality, in what you do is, a degenerative brain disease in adults, and what I do it tends to be more muscle and some neurodegenerative diseases in kids and young adults. Our patients really want our opinion, and it's a time-based opinion. And what's happening in 2021, so 7-8 months down the pipeline, is our coding is going to change completely. Our E&M coding is going to go from this bullet-based coding for details about history and physical examination to solely based on two things. What is your medical decision-making? And, the rubric for this is available. Here it is. I've been looking at this for years, and it still boggles my mind in trying to figure out how to fill this out and determine what medical decision-making is, or it's based on time. And the really neat thing about 2021 that's actually relevant maybe today, and I'll get to that in a minute, is that time is not just the time you spend with the patient. Time is it starts at midnight of the day of service. So if you want to start, trying to do pre-charting at midnight on the day of service, and then your visit's 8 o'clock in the morning, it's the time you spent pre-charting, it's the time you spent planning that visit, it's the time you spent in that visit with the patient. And if you need to do things after that visit, whether it be call other clinicians to work out a detail and plan, if it's to do research, it's to finish the charting, that counts too. But if the day of the visit is April 24th, 2020, it's only the work you do on April 24th, 2020 that counts as time. And if that's 57 minutes, it's 57 minutes, even though you may have only spent 15 minutes with the patient. Now, what's going to be able to be tracked eventually is, how many hours you were actually billing for during that day. And if you're billing for 23 hours a day, someone's going to catch you. But the point being is that the definition of time is how we use it in our billing changes dramatically on January 1st. And I say, boy, isn't that interesting? Because yesterday on April 23rd, 2020, CMS issued a statement saying, oh, by the way, if you want to use time, using the 2021 rules, and it's confusing, but you can start doing that today. And this is for Medicare patients. So we really don't know what's going to happen tomorrow in terms of what the other commercial insurances are going to pay for this. So time really becomes important. How do you keep that track of that time? A stopwatch. That's the only thing I can tell people to do right now is, lawyers have figured out a way to do it. Lawyers bill in 15-minute increments. We bill in 1-second increments, and it's got to be the total time you spend. So, if you want to do it right, you're going to have to use a stopwatch and a piece of paper to record all the time you spend on a patient. I lost the audio.
Oops, I'm sorry. I was coughing, so I muted. I apologize.
Okay.
Hollie, when it comes to time coding, how have your telemedicine visits gone? Have they gone more easily than an in-person visit? Are you spending more time with patients to accomplish the same amount? Obviously you're not able to do the full examination, so maybe that cuts off a little time, but are you spending more time in other ways? Also maybe we don't have the blood work that we would usually have, or the procedures or the cognitive tests that you usually have. Kind of how have your days been going, and how has that impacted care?
Yeah, I mean, I definitely feel like I'm spending the same amount of time, if not more, with my patients. I think at this time, a lot of it is, I don't want to say counseling, but a lot of it is conversation about the current events and then how it's affected them. I mean, even anxiety is up, stress is up, people can't sleep. So I've really noticed that with a lot of my patients. So, talking more about that, talking about sleep hygiene, talking about, stress modification. So yeah, but I mean, I think the timing is about the same, and, minus the physical exam, obviously that's not there, but yeah.
Yeah, it's interesting because most of the patients I've been seeing, this is a visit about cognitive function and how's memory and what can we do to reduce risk and what can we do to treat memory loss and all the different things. But most 90-something% of the patients I've been seeing, this is the first doctor appointment they've had during the pandemic. They've been at home, period, for a month or whatever it is. And invariably 10, 15 minutes, I would say on average of each visit, which can take 30, 45 minutes, an hour, at least 10 or 15 of those on average are talking about COVID-19. They ask about what they should be doing. They ask about questions, anxiety. They have a family member. They may ask about that. So it's unique. In some ways, I feel like a primary care physician, but that's okay. All of us in a lot of ways are COVID physicians, whether you're a cardiologist, a neurologist, a pediatric neurologist, we're all taking care of COVID-related something in some degree. But I agree. It's interesting that the appointments are getting longer in terms of the counseling. Yeah. So the coding works with the time coding, but they're getting shorter with other ways. But I haven't seen care compromised yet, which is good. Care is sometimes harder because we don't have all the information. But in terms of the coding aspect, it's I guess what I would say is it's working. I guess it's working. We can hopefully make ends meet. Bruce, when you just mentioned that rule change, which I hadn't heard about, so I'm really glad you mentioned it. How do you think this COVID-19 experience may continue to change the way neurologists have to pay attention to coding? Obviously in 2021, a lot of things are going to change. Some of that's changing now. Do you think that there's going to be a tidal wave of modifications in the way that we do things? Or do you think maybe this is just a short-term, medium-term change or fix, or what do you think of the landscape?
So there are a couple of things that happened with the COVID-19 public health emergency declaration on March 6th of this year. The first thing that happened is HHS basically said to all the states, you guys get to determine whether or not a physician in New York City can do telemedicine services on their patient who lives in New Jersey.
Right.
Without that New Jersey medical license. Now, again, I'm not sure, how doctors in New York City gather their medical licenses, but doctors in Ohio, we have an Ohio license. And we actually have a hospital that we own on the border of Ohio and Pennsylvania. And most of the patients who are seen in that hospital come from Pennsylvania. But none of our doctors providers have medical licenses in Pennsylvania. We've given them telephone services for years. Yeah. So, it's been ignored by state medical boards because it amounts to doctors giving away care for free. So why would we bother them about the medical license? But now that we can charge and get paid for it, I think state medical boards, when COVID-19 public health emergency ends and the rules go back to they were the way before, the state of Pennsylvania may want that Ohio physician having a medical license in Pennsylvania, and the state medical board in New Jersey may want you and the nurse practitioners and physician's assistants to likewise have medical licenses in New Jersey and Connecticut. If you're based in Boston, you're going to have to get a Rhode Island medical license. That landscape just hasn't been defined yet as to what's going to happen. I think this is going to change. I think people are going to like this a lot. When you think about a patient needs to come see you, their family, which may include, 2 kids, need to take a day off from work, drive into the city, park their car. It's a whole day experience. It's a different experience in Ohio, but they have to drive 2 hours to come see me. I've had patients roll out of bed this morning. We started the visit at 7:30 in the morning. I'm here dressed like this in my office, and they're rolling out of bed, and they love it. They didn't have to get up at 4 o'clock in the morning. Right. The family that lives in Kentucky so I think it's going to change things.
Yeah, it would, from my perspective, I think from Hollie's perspective too, that would be a very welcome change. My understanding, and I hope this is right, we are allowed to see, oh boy, I hope this is right, it's being recorded, but I think we're allowed to see follow-up patients if they're not in New York. I'm pretty sure that, but I don't know exactly the radius or the state radius, so I'm not going to say anything, but I think that's okay. But I think the rules that I've read state that we're not allowed to see new patients unless they're in New York.
So this brings up a really important point. The federal guidelines say it's up to the states, but the states can waive all the rules if they want to. I don't know what the deal is between New York and New Jersey, but as I understand it, pretty much all 50 states have said, we're not going to, if it's telemedicine, we're going to remove that barrier. Okay. If it's you traveling to New Jersey to see a patient in their home, you better have a New Jersey license for that. Now that's a federal laws and state laws that have waived it. But then you've got your institution laws. So your institution may say, yeah, you can do this for established patients, but don't try it for new patients. We want new patients to be face to face. Our institution has gone with the federal rules the Medicare rules that basically allow us to access new patients, both with telemedicine, audio and video synchronous services, but also with just telephone services, which is, heresy, a month ago. And now people are doing it because it's allowed to be done. Now, whether you want to do it or not, and whether your institution wants you to do it or not, are very important. So you really have to follow the rules of your institution.
So, Hollie, I wanted to get your input about, the difference in, as Bruce said, the method of delivery. So we talked about synchronous and asynchronous, then we talked about video versus telephone. Yeah. And, billing or reimbursements, whatever it will be for telephone is very low, like extremely low. But I think a lot of people think, especially in a cognitive or neurodegenerative disorder specialty, that older patients have trouble with video and, it's just not going to work. So just do it on the phone. Yeah. I want to know what your experience has been. And you've seen patients all ages, I guess 30s, 40s, 50s, 60s, 70s, 80s. What's been your experience? What percentage of your patients, have the appropriate technology to participate in a video visit. Have most video visits been gone through the medical record, or has it been through Zoom or whatever else, or FaceTime, or Doximity, I think has a way to do it. Or what percentage of the time have you just, the patient needs care, they're not able to connect through video, let's just hop on the phone? What has been the percentages, and also the age distribution?
Yeah. So in terms of percentages, I think, probably at least 80% have access to video. So we can do it, or they have to have like an iPhone or iPad. So that's been good. And those people their ages are, 30s, 40s, 50s, 60s. I've had a few patients with memory complaints in their 70s and 80s that, probably 10% of my patients that haven't been able to connect via video, unfortunately. And I really honestly like to see them via video. I think it's really important to, kind of connect with those people as well, of that age. But my patients seem to really don't mind it. They seem to actually kind of enjoy it, especially right now, like being able to connect and see somebody in person. It's nice. So, yeah.
Cool. So it hasn't, there's, I'll quote some statistics. I think these are correct, but I think 96% of Americans have a cell phone. I think that's the statistic I read back in 2018. 81% of Americans have a smartphone.
Yeah. So
that facilitates things. Obviously, there's age barriers and technology gaps and all that kind of thing. But it seems to me, we have computer ways, we have a variety of different ways to reach out. And it seems like the majority of people are not having trouble with telemedicine visits through video. Bruce, I guess some practical questions that have also happened to me. So let's just say I'm on a video visit. The video visit crashes, can't get it to work. And then I try another video way, it doesn't work. So I spend 15 minutes or 20 minutes on the video, it crashed, and then I have to go to the phone. How do you code a visit like that? That's a tricky thing. Or what if you spend 20 minutes on a video and then you have to switch video to a different platform or something? Does this matter when it comes to time coding? What are the issues, and what are the requirements when you change distribution channels?
Yeah. So my view of all this is very strict and very conservative. So if you've never established the video contact and it's all audio, you really have to bill it as a telephone visit. If you establish video contact and you get what you need out of that video in order to fulfill the requirements that you would need to bill for medical decision making. So if all I really need to understand on that patient is what their finger to nose exam looks like and their gait looks like, and once I get that information, I'm good for my medical decision making. Then, and let's say it crashes 8 minutes in or 3 minutes in, but I got what I need out of that video, then I would bill it as a synchronous audio video, a regular E&M, 99214 code. And then you'd add a modifier on to, indicate that it was a telemedicine, a synchronous visit. That's okay. The federal laws allow for these to not only take place over your HIPAA compliant portal, but as long as it's a relatively secure other portal that you and the patient only have links to. And I'm not going to give proprietary names of the software, but they're out there. You could reestablish that contact that way if it's okay with your employer, and finish up that way, or just convert over to telephone. So I had a patient today where just because they couldn't get onto the video, I called them via Jabber, which is totally compliant, HIPAA compliant. It's a phone call. And I walked them through how to get onto the video. And by the time they got on the video, we had actually done most of the visit. They had to download the software. I had gone through the med list. I went through the problem list. I actually did review of systems and took the patient's entire history since the last visit. And really what I wanted to see is some nuances with his coordination exam. Yeah, that was done. We probably were only connected by video for 5 minutes, but I got all the information I needed. And I billed that as a synchronous telemedicine visit.
You mentioned at the beginning, you said if there's time at the end, I wanted to cover one more thing. Slip my mind. It's in my brain.
Yeah, so again, we talked a bit about telephone. We talked a lot about the audio-video link. We didn't really talk about the digital transfer of information.
Right. That's right.
And this is when patients push a question to you like, 3 weeks ago, you put me on gabapentin 300 milligrams TID for my neuropathy,
Right.
and I want to let you know I'm feeling better, but gosh, is there any way we can go up a little bit more on the medication? And then you respond back saying, yeah, go up to 600 milligrams TID. Well, that took you 2 minutes. Okay, that doesn't get you to the threshold to submit a bill, which is for that service.
5 minutes.
You need at least 5 minutes.
Okay.
But if the back and forth is, which is an interesting code because those digital codes tend to be back and forth. They're written to be back and forth for up to 7 days. Then you can, if it's more than 5 minutes over that course of 7 days, that means you can only bill it once every 7 days per problem. Then you can actually submit a bill. But the other one was interprofessional consults. And so this is where the patient doesn't exist at all. What exists is me. A patient of mine has headaches. I get a CT scan that shows massive sinusitis, and I need to call my consult infectious disease because I don't know the first thing about antibiotics, but I also think it's ridiculous to wait 3 weeks for him to see an infectious disease doctor. And so I would call him up and I ask him the question, what antibiotic should I use? He may want to look at the CT scan as long as he spends more than 5 minutes doing his side of the work and gives me a verbal and or written set of instructions. He can bill for those for his services. If I, as the person asking the consult, spends more than 30 minutes in asking the consult and then getting the information back, I can submit a bill. But it really allows the neurologist, we tend to be on the receiving end of these consults. Mm-hmm. It allows us to actually give our opinion about a patient without having to actually see the patient in the first place and get paid for it.
Gotcha. And so you would have to tell the patient, this is what you want to do. Say, I would like to get an opinion from a colleague. And then your colleague then bills their insurance, but is there a copay or how does that work?
It would be copays like with anything. So usually your colleague would, really for the neurologist, what it's going to be like, the general practitioner sees this patient he's been following for 30 years and says, gosh, I think you got Parkinson's disease. And I know what medicine I want to start, but I just don't know the dose. And can I consult with a neurologist? And that provider is going to call you up as a neurologist, say, I got this guy here. I think he's got Parkinson's disease. You're going to back and forth information, and you're going to say, yeah, it's reasonable to start, pick a medicine, Cinemet, and this is the dose I would use. As long as you, as the neurologist, have spent at least 5 minutes gathering that information. And again, there's some nuances about how it's got to be documented. You, as a neurologist, will get paid. Since the referring doctor, the internist, probably can't meet his 30-minute threshold or her 30-minute threshold, they're not going to get paid a penny for it. But you, as the consulting neurologist being consulted, will get paid for that visit. There's some nuances, and it takes about 20 minutes to explain how these are used. But it's going to be a fun set of codes for us to get involved with because it allows us to give care fast for our patients.
How long have those codes been available?
Not very long.
Okay.
They were added in the last year or so.
Okay, great. Well, I am definitely had not been aware of this and something I would love to learn about. That's great. One final question. Say a neurologist wants to do a visit on a patient, but the primary care doctor would like to see the patient together. So they both see the patient at the same time. It's conceivable. In our practice, we haven't done this too much, but it could be helpful because it cuts down on all the back and forth and phone calls and everything else. If two separate physicians and separate specialties are seeing the same patient at the same time along those lines, is that billable separately or not really?
Depends on the insurance company. So we run 13 different multi-specialty clinics at our institution. So we have a neuromuscular multi-specialty clinic, which will include in the same room at the same time a neurologist, a physiatrist, a geneticist, sometimes an orthopedic surgeon. And when we do spasticity clinic, it also can include a urologist and so forth and so on. It really depends on the insurance company on how they want that billed, because you can only bill one practice expense, right? Because the patient only gets their blood pressure done once. They only get put into one exam room.
Right.
It does get very complicated, and you're going to have to work out the details with insurance companies.
Gotcha. Okay. Well, that's helpful. Well, that's an outstanding overview. I learned a lot. Hollie, thanks so much for giving our practical, boots on the ground opinion about how things have been going. And Bruce, thanks so much for your expertise. Aside from going to the AAN.com website, aside from going to YouTube with the Neurobytes coding, a 3-minute bite that I believe you actually did the voiceover for recently. And aside from the telemedicine webinar, the 60-minute one that came out at the end of March, any other resources that you guys have used that you'd recommend to people who are watching?
Sure. So again, a little bit of self-promotion. If you go to akronchildrens.org and go under the CME and then go under Enduring Materials, I've given a 90-minute seminar. You can get your free CME credit if you go watch it, and it's a talk on all the things that we talked about today.
Okay, that's great. Hollie, what types of tools have you been using? Kind of the stuff that we just talked about.
Yeah, I've listened to all the same things, so it's great.
Yeah.
Thank you.
Cool. Okay, thanks so much, guys. Appreciate it. Stay safe out there.